We move on to a keynote talk by a dear friend, Dr. Puran Chandra. Due apologies to the speakers of the next session because of first day of the conference we started little late and couple of the speakers were unable to come on time. Just last talk of this session, Dr. Puran Chandra, over to you, please.
Thank you, sir. So this was the paper which I presented last year. It's on comprehensive approach and exploring therapeutic potential in retinal dystrophies. So as we all know, like field of genetics is evolving at a very high pace. It's surprising to know that eye is the second only to the brain as an individual organ in its frequency of involvement in genetic disorders. And almost 50% of pediatric disorders will have some genetic etiology. And clinical pictures sometimes could be overlapping and may not be enough because it may range from a very subtle clinical changes in stationary night blindness to a very severe early onset degeneration in cases of LCA. So these are the symptoms with which the patient present: night vision problem, normal central vision, but tunnel vision, central scotoma, photophobia. Some parents bring their children stating that they're not doing well in the school, and some are concerned, I have this condition, that's fine, will this condition pass on to my next generation? So what we do, as of now, we counsel them, offer them low vision aid services, we provide photochromatic glasses for the photophobia, and we monitor the disease. So due to its rarity, the clinical modules of dystrophy has not been studied extensively in India and needs to be comprehensively analyzed along with the disease phenotypes. It was an observational study approved by institutional review board and informed consent were taken. So we studied a total 45 patients in the age group of 5 to 31 years, and there were 31 males and 14 females. So all patients underwent a comprehensive eye evaluation including imaging, and electrophysiological tests were done with strict adherence to ISCV guidelines wherever it was required. So coming to the genetic testing method, we use something called next generation targeted sequencing using a 212 retina specific genes, and a variant calling in the genes of interest was looked into. So we got 45 different mutations in these 45 patients. Among these, 9 mutations were unreported, and these nucleotide changes were not present in the 100 normals which were analyzed, and 36 variants were previously associated with retinal dystrophy. So we had 9 novel mutations with the existing spectrum of genes identified in Indian patients. So it provides further information on the genotype-phenotype correlation for the retinal dystrophy. So what does all this means to a patient, the imaging, genetics? I would like to highlight the same by giving these two case example. These two patients, both of them presented with blurred vision. Fundus looked normal clinically. Whereas the first patient had a very subtle changes in the foveola and the autofluorescence, whereas OCT showed subfoveal cavitation. So when we did an ERG, dark adapted responses are completely normal, but if you look at the light adapted responses, so it was unrecordable. So the defect is so small, the cones in this entire retina are non-functional. So second patient had obvious atrophic foveal changes in autofluorescence, and same was confirmed in OCT, which showed foveal thinning with outer retinal loss. But look at this patient's here, it's almost like near normal. So why there is so much of functional difference between the two clinically normal looking fundus? The reason being the first case is a case of achromatopsia caused by a mutation in GUCY2D gene, which is a stationary disorder. The patient is born like that and is going to live like that. We need to counsel and plan his career accordingly. The second case, though it looks functionally normal now, it's a Stargardt's in its earliest stage, and this patient had a mutation in ABCA4 gene, and this is likely to progress, and we can take some measures like avoiding vitamin A supplementation, protecting them against light to prevent progression to an extent. So what are the future direction? Of course, obviously we need to do gene therapy for all these patients, which basically involves injection of adeno-associated virus vectors to correct the defective gene. So this is the complex process which involves the preparation of this gene therapy product. I won't go into the detail. Basically, there are 3 steps: transfection of the 3 plasmid lines into HKE cell lines, and these are harvested 65 hours later, and they will undergo purification by affinity chromatography and ultracentrifugation, finally resulting in AAV vectors. So these AAV vectors we injected in mouse subretinally. So we used beta galactoside enzyme, the gene which codes for this enzyme. And this is the injection site in the mouse, and we also use green fluorescent tracking system to whether the vectors are in subretinal and how is the uptake. The uptake was good, and these eyes were harvested 2 months later. If you look at the negative control, there is an excellent uptake and beta galactoside activity which was seen in the mouse which received this gene, viral vectors. So we have a dedicated gene therapy production platform with an expanding team of scientists. So we also built a class 100 clean room facility. So class 100 clean room facility basically means that the sterility of these OTs are 10 times, they are 10 times more sterile than the regular OTs what we use for retinal surgeries and the cataract surgeries. So this is first in India. And the national gene therapy guidelines are also out, and whoever is interested in knowing the guidelines on gene therapy, this is available in the ICMR website. You can just go and download the PDF. So I always conclude any of studies under these three headings. What we already knew was diagnosis of retinal dystrophy means almost end of road to the patient. What this study adds is there's more database and Indian database for mutation. We detected 9 novel mutation out of 45. That indicates the Indian database for mutation may be different. We can't just follow the whatever that is reported in the West. And there are subtle changes which can make a big difference in how we counsel the patient and manage the patient. And the rodent model was also studied. Of course, the future direction will be to start first in India humanized gene therapy. Thank you so much.
Thank you, Puran. And because it's a keynote lecture, we cannot ask you any questions. On a lighter note, thank you so very